Welcome back to NGN Deep Dive. Today, we're at the very top of the ABC priority list. Airway and breathing emergencies. Epiglottitis, ARDS, pulmonary embolism, and chest tube emergencies. When these go wrong, you have seconds, not minutes. Roadmap. Epiglottitis and its forbidden assessment, ARDS, and refractory hypoxemia, pulmonary embolism, chest tube emergencies, a head-to-head, and practice from days 13, 17, 8, and 28. Chapter 1. Epiglottitis. A rapidly swelling epiglottitis in a child that can obstruct the airway completely. The nursing priority is to avoid anything that could tip a partial obstruction into a complete one. The classic picture. A sudden high fever and severe sore throat, then the 4 Ds, drooling, dysphagia or trouble swallowing, dysphonia or a muffled voice, and distress. The child sits in a tripod position, leaning forward, anxious, and very still, refusing to lie down. Stridor means the airway is closing. This looks like a child working hard just to breathe. The traps, and the first is the forbidden assessment. Do not inspect the throat with a tongue depressor or swab. That can trigger a complete obstruction. Don't lay the child flat. Keep them upright and calm in whatever position comforts them. Don't separate them from their caregiver, because crying and agitation worsen the obstruction. And never delay airway readiness. Keep intubation and tracheostomy equipment right at the bedside. Chapter 2. Acute respiratory distress syndrome. Widespread inflammation floods the alveoli, so oxygen can't cross into the blood no matter how much you give. Here's why the oxygen won't work. A lung injury from sepsis, aspiration, or trauma inflames and damages the alveolar capillary membrane. Fluid leaks into the alveoli, surfactant is lost, and the alveoli collapse. Gas exchange fails, and you get refractory hypoxemia, a low oxygen saturation that barely budges even on high concentrations of oxygen. That refractory piece is the hallmark that separates ARDS from ordinary hypoxia. Management supports the lungs while you treat the cause. Mechanical ventilation uses low tidal volumes, lung protective ventilation, to avoid overstretching fragile alveoli. PEP keeps the alveoli open and improves oxygenation. Prone positioning, turning the patient face down, genuinely improves oxygenation in severe ARDS. Treat the underlying cause, often sepsis, and watch for barotrauma. Chapter 3. Pulmonary embolism. A clot, usually from a leg DVT, lodges in the pulmonary circulation, suddenly blocking blood flow to part of the lung. Recognize it fast. Risk factors. Immobility. Recent surgery, a known DVT. The critical picture? Sudden shortness of breath and pleuritic chest pain, a fast heart rate and fast breathing, hypoxia, restlessness, sometimes a sense of impending doom, occasionally hemoptysis and, if it's large, hypotension from obstructive shock. The word to remember is sudden. Priorities: high flow oxygen, and sit the patient upright to ease the work of breathing. Assess and support the blood pressure. Start anticoagulation / heparin, unless it's contraindicated. For a massive PE with hemodynamic instability, thrombolytics may be used. And prevent the next clot with DVT prophylaxis. Oxygenate. Stabilize. Anticoagulate. Chapter 4. Chest tubes. The exam tests what you do the instant something goes wrong. A disconnection, a dislodgement, or continuous bubbling. If-then rules. Memorize these. If the tube disconnects from the drainage system, submerge the end in sterile water to re-establish a water seal. Dith Krasik rules skill. Do not clamp it, because clamping can cause a tension pneumothorax. If the tube is pulled out of the chest, cover the site with an occlusive dressing, taped on 3 sides, so air can escape but not re-enter. Continuous bubbling in the water seal chamber means an air leak. Check the connections first, then the system. And if drainage suddenly stops or the titling disappears, check for kinks or clots, because an obstruction can build tension. The traps. Don't clamp for a disconnection that traps air and risks a tension pneumothorax. Use a water seal instead. Don't tape an occlusive dressing on all 4 sides. A fully sealed dressing can create a tension pneumothorax, so you tape 3 sides. And don't routinely milk or strip the tubing. It generates dangerous negative pressure. Head to head. Head to head. Epiglottitis is an airway obstruction, the 4 Ds, tripod, stritter, where the trap is inspecting the throat. ARDS floods the alveoli with refractory hypoxemia, and the trap is expecting oxygen alone to fix it. P blocks blood flow with sudden dyspnea, and the trap is missing that sudden onset. Different levels of the airway breathing chain, different first moves, practice. From day 13. A 4-year-old with a high fever, drooling, a muffled voice, sitting upright, and leaning forward. Which action should the nurse avoid? Pause and choose. The answer is C. Avoid examining the throat with a tongue depressor. This is classic epiglottitis, and inspecting the throat can trigger laryngospasm and complete obstruction. The other 3 options are all correct care. Keeping the child calm, upright with the parent, and airway equipment ready. The question tests whether you recognize the one maneuver that can kill. Provoking that swollen epiglottitis. Second question. From day 28. A client's chest tube disconnects from the drainage system. What does the nurse do first? Pause and decide. The answer is B. Submerge the end in sterile water to re-establish a water seal. That lets air escape the pleural space while preventing air from being pulled back in. The classic wrong answer is A. Clamping. It feels protective, like stopping a leak, but it traps air in the chest and can rapidly cause a tension pneumothorax. Water seal, never clamp. Synthesize it. Center. Chest tube disconnection. Actions. Submerge the tube end in sterile water, do not clamp, and assess respiratory status while notifying the provider. Monitor the respiratory rate, effort, and oxygen saturation. Watch for signs of a tension pneumothorax, and confirm titling and drainage once the system's reconnected. That's the chest tube emergency handled correctly. That's the airway and breathing emergencies, epiglottitis, ARDS, pulmonary embolism, and chest tubes. Daily NGN questions at 5. Every guide free at ClinicalJudge.com. Subscribe, comment your score, save the series. You learned it. Now go apply it.